So welcome everybody to SEVA VentRounds. Today is August 13, 2024. And these are 3 trying triggers. And we're going to focus on reading waveforms.
Oh, I couldn't hear it.
I'm going to mute Michael. Alrighty. So, disclosures, no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinics. Your hosts are Rob. Rob, say hi.
Hello.
There you go. And myself, Eduardo Mireles. Here are our conflicts of interest. The ground rules: keep your microphone muted. These are recorded sessions. The moderator may call upon members of the audience to comment, but if you want to chat, absolutely unmute yourself, make your comment. We're happy to hear it, or use the chat function. We are also monitoring that all the time, so that's very useful for us to see. There is CME and CRCE for all of you that recognize those letters. If you're at respiratory therapy, we get the attendance, and from there you receive credit. You have to complete an evaluation. So let's start by just a basic SEVA knowledge, which is trying to classify the problems with triggering. And what you see here are the 5 types of trigger problems that you will find out there. The first one is that it's normal, and everybody's happy with that. And the definition of normal is a little bit challenging because we have said, well, it has to happen as close as at the initiation of PMOS as we can. You see here on red, the red line, and then the pressure drops, and then the breath starts, and you can see the flow crossing the midline. You're controlling pressure, so you see this is a flow trigger, and immediately it crosses the baseline and it triggers the breath. So we will consider this normal. I mean, it's something that is not clinically significant, but in reality, we don't have a good measure. There is no ventilator to my knowledge, and Rob, you can jump in, but that does measurements of the trigger time to make us aware of a late trigger or not, or an alarm of such style.
I don't think so.
And so what we're left with is our high quality eyesight to try to determine if this is relevant or not. So immediately after normal, I put an exaggeration of 1 in which you can see a late trigger, and you can see how the PMOS starts dropping, the pressure starts dropping. There's always some degree of lag, just as you saw over here, but it takes a fair amount. The pressure drops. This is a pressure trigger, and then eventually, boom, it triggers the breath, pressurizes. But if you notice PMOS, it was just about to peak, so the majority of the breath was unassisted in a way. Actually, it was a loaded breath. The patient was trying to breathe against that. Rob?
Just to point out that these waveforms were made on a lung simulator. And so that dotted line that shows PMUS is what is being generated by the simulator. You won't, of course, see that on a ventilator, at least not yet. And the other thing to point out is this particular simulator happens to plot PMUS upside down. So PMUS on inspiration should always be positive, but they show it as negative, so it's just easier to see.
Excellent. Thank you, Roberto.
Mm-hmm.
Then you have an early trigger, and the early trigger means that the patient, remember the patient is the reference, starts before the PMOS. And so you have a mandatory breath, and we recognize that by a couple of things. One is, if we look, this is a pressure controlled breath, we look at the flow trigger and we don't see any evidence of PMOS at the flow waveform, and you don't see any evidence of PMOS. And then you see evidence of PMOS both in the pressure waveform and on the flow waveform. You see that increment there with a drop in the pressure, and that's the presence of PMOS. So the classic pattern is mandatory breath followed by evidence of PMOS. And it can happen at different parts. It's very nice papers out there talking about when it happens very early, mid-breath, or very early in exhalation. The pathology or the consequence of such is still a matter of speculation and investigation, so we still don't know very well. Then you have a false trigger, and a false trigger, essentially, there is no PMOS. You see here that dotted line, there's no PMOS at all, but the ventilator is identifying a signal that it thinks that it's PMOS, and so it's triggering. You see the white line here in this highlight is saying, oh, the patient is triggering, but the patient is not triggering. This is due to a very large leak. And then you have the last type, which is a failed trigger. And here what you have is the opposite of this one. This one, there was no PMOS. In this one, there's PMOS, but the ventilator fails to detect that. And we recognize that by this move up of or approach towards the baseline of the flow waveform. And sometimes you can even see it happening on the pressure waveform. You'll see the drop over here, and this would be what we call the failed trigger. Again, in the literature, there's all these other numbers, names that are used. We use these names. We're happy with them. Roberto, comments?
No comments.
All righty. So here comes the image as usually. When we put the image out, I want you to, we're going to go in order of reading, just following the goal-directed ventilator management checklist. Okay? Here we go. And this is actually from a real patient. And I know Ariel hates when I put images that are not high quality. You can see him there retching, but this is a very high quality image. And actually, you can barely see me reflected on the image, Ariel. So smile, please. This is positive image. So let's start by the tag. So if you see this, I see Arsal at the lead just putting down what he thinks is, and we're not hiding anything. I mean, the ventilator gives you up here what the mode is. You can see it up here. And so any other comments on the tag? But indeed, this is a pressure control CMB A. And that means that the breath control variable is pressure. We're controlling the pressure during the inspiratory phase. All the breaths are mandatory, and that means that we have set in this case, an I time for the breath. So it cycles. It can be triggered by the patient, but it's cycled by the machine, every single one of them. And A for adaptive, and adaptive means, and this is one of the modes that confuses everybody because of the way that they did it, is that you see tidal volume set here, but it's not a volume control mode. It's a target that the ventilator is trying to achieve. So it's calculating what the tidal volume is on the last breath. And then if you actually pay an attention to this for a second, and although these are not sequential, but this identifies it, you probably can see it. It's the same concept, that the pressure from this breath to this breath is lower. And so, although they are not sequential, I'm repeating that, but for the example that I'm trying to voice here is, in this breath, the tidal volume was higher, so the ventilator drops the pressure for the next breath to try to get the tidal volume within range. And so that's what the adaptive is doing. It's adapting the inspiratory pressure to achieve happiness. Roberto?
That's well explained.
All righty. I would highlight, and Ariel has made a good point here, which is voicing to us that the auto mode button is not active. And he's referring to this little item here. The new ventilators make it more evident, but in the past, if you would have pressed or activated the auto mode, it would have changed this mode from this targeting scheme to a much more complex targeting scheme, which is not the case here, but it would have become an IMB type 2 mode. So, all righty. So the next thing is to ask the group, what is the load? Elastic, resistive, or PMOS? And look at the waveforms, and during inspiration and expiration, what is the load? Elastic, PMOS, resistive. I see some of the answers coming in, and I'm going to give you a little tip that may help you. Is sometimes you have waveforms across the screen, and you're going to see evidence of PMOS. But there's going to be some waveforms that will have no PMOS, meaning there was no activation of the muscle, and those may allow you to take a look at actually what was happening to at the physiology of the patient. So just as you evidently recognize that there's PMOS in some of these waveforms, and that is altering the waveform, but perhaps this one over here has very little PMOS. It was not triggered. It was triggered by the machine, and it seems to decay mostly exponentially, and it's probably within half a second of time. And so that will, that will make you suspect that this is an elastic load just by looking at that one over here. And then you can see in the second, in this breath that I'm pointing out here, actually the patient has no more PMOS, so the flow goes to baseline, then the ventilator I time stops, and the patient exhales, and you can see that it takes less than a second or around a second of time for the patient to exhale. So that is also consistent with an elastic load. But without a doubt, you're not wrong by saying, Eduardo, there's a lot of PMOS in there. So it's important for you to just recognize that when you're looking at the waveform, whenever the patient relaxes, you may have a couple of breaths out there that will help you see beyond the PMOS. Make sense, Roberto?
Yep, looks good.
All righty. So now comes the triggering part, and the triggering part is key here. And I would ask you to go in order. So what I'm going to do is I'm going to number the breaths on the screen. So you have breath number 1, 2. I'm going to call this one 3, 4, and 5. So go at it. What do you think is the triggering problem here? It's a lot of them, right? This is one of those that makes respiratory therapy continue to have a jobs, because this is classic I need help image. I'm starting to see some come in. Okay. Remember, challenge yourself, put it out there. It doesn't matter. The chat is not visible to the universe. We can only see it today here. It's good. It's a good exercise for you to try yourself of understanding what's going on. And I'm taking for you guys that are watching us in the future, just keep thinking for us a little bit. The answers will come in a second. Test yourselves. All righty. So let's start with breath number 1. Okay. So breath number 1, as you see on breath number 1, you see the changing color, and the changing color is telling you that this is a pressure trigger breath. And you can come and see that the pressure is set at 5, right? And the patient drops the pressure actually deep, and it goes a little bit below 5, and then it triggers finally, boom. So, and over here you can see that the flow actually crosses right along, and then immediately it pressurizes. So I would say that even though this is a marked drop, that's probably because the patient has a high respiratory drive. And I would say that just based on the way that the flow waveform looks, this looks like a normal trigger. So I would call the first one normal. Disagreements, Roberto?
I agree.
All right, so that's good. Breath number 2 is a mandatory breath. And we see that because there's no evidence of PMOS, so there's no deflection, drop in the pressure, there's no crossing of the baseline. and there's no change in color. So that one is out of the count. We're not gonna count that one. But breath number 3, what do you guys think? Normal, early, late, false, failed?
So hi,
Yeah, go ahead.
so if breath number 2 is normal, then I would think I'm not sure. I thought always I'm very familiar with ventilators, but I'm being little bit confused. So if breath number 2 is normal, then I would think number 3 is early. But this patient is pressure is on PRVC. Then this is pressure regulated volume control, or it's another mood.
Yeah, it's pressure regulated volume control, PCCMBA.
Okay, so pressure regulated volume control. It is a controlled mandatory ventilation with some assist, and the patient volume is given mainly with a concern to his airway pressure. So I would think this is early. I would say 3 is early.
This is a good discussion. I see that I have a couple false, an early, another early, another early. So if you see this is a mandatory breath, there's no evidence of PMOS. Remember, we always look at the flow waveform when you're controlling pressure, which is the case of this mode. So because we're controlling pressure, we come down here, we look at the flow waveform during inspiration, and it looks passive. Then the patient exhales and it rapidly goes towards baseline. And you can see that there is this period of time that I'm going to highlight here in red. You see that? In which the flow is at baseline. And actually, if you come all the way up, you're going to see how the pressure is dropping. You see that?
I see.
Boom, 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 boom. So the PMOS of this patient, it started actually right here, where I'm putting, even though the breath triggered all the way over here, the breath started really early after the exhalation happened.
Okay.
So in terms of how to define this one, if we follow, this is one of those breaths that falls into, we have to come to consensus of when do you call an early or an early or a late trigger, because you could call this a late because there's this pause here and the patient is doing PMOS. But the patient barely exhaled, and it's at the early part of the breath. So in some of the publications, this would be called an early trigger because it's a mandatory followed by evidence of PMOS on the early breath. And I would be aligned to calling that, but I'm open to thoughts, Roberto.
I would disagree because the inspiratory effort has to occur after the machine trigger, but before the machine cycle. It has to happen within the defined inspiratory period. And this does not do that, right?
Yeah, you're absolutely right. The problem is that when they did the analysis of the phenotypes, they found one that fits all the characteristics of a reverse trigger, the periodicity, the entrainment. But and this could happen if you think about it, just related to the how much set eye time you have. So if I set an eye time that is short enough, it would fall into another classification that if I put an eye time that is long enough, it may fall within a late exhalation type. So yeah, it's a good question, Rob.
Yeah, you gotta lay a line in the sand and say this is the definition, and either it fits the definition or it doesn't.
So it's either a late or an early, depending on how the definition comes to be in general terms. The way that we have defined early on, I think that on the manuscript we put early exhalation. I have to take a look again, but that's a good point.
Yeah, I don't recall the exact wording, but this is a situation when you have to go back to the exact wording, and if it isn't detailed enough, then you have to add detail. But I think we did say within the defined preset inspiratory time, and the reason why I would call this delayed is because the patient, it looks like he's trying to trigger during the refractory period, right?
No doubt. No, that's actually, this is a great image of a well, I was gonna even ask you that, Roberto, because I was having some conflict. So do you think this is a refractory period, or do you think this is the patient the ventilator is blocking so that it can generate enough pressure to trigger a pressure trigger?
My guess is that it's a refractory period because the patient's making an effort and the airway is occluded, right? There's
Okay.
no flow.
Perfect. Very good. And then you have breath 3. We finished breath 3. Breath 4 is another mandatory breath. And I always like to compare how this falls between the two passive breaths, and it's pretty close. Actually, you can see the tidal volume is almost very close. And the expiratory flow seems to be pretty close. So I would say that there's no PMOS there. But then again, the same thing happens. You see that? In which actually, in this case, Rob, this is too long to be a refractory period.
That's exactly right. And I've been thinking about that a lot. I don't know what that is.
So the patient drops the pressure for a long period of time. And this is a pressure trigger again. Remember this pressure trigger, but it cannot achieve it during all this time. So this looks to me as a failed trigger due to pressure trigger. It's a pressure trigger set too low to try to put this patient under control. I presume that's the only reason. And then it relaxes PMOS and the pressure goes up and the flow goes out, and then boom, he gets the last breath that it's also mandatory. It's not a patient trigger breath. It's a mandatory breath. So I would say that the breath that we didn't count, which is, I would say this one over here, is a failed trigger.
Yeah, because the patient probably got tired out. I don't think the effort is as big as between 2 and 3, right?
No, I mean, it was
it'd be very interesting to know what the trigger threshold was, because on breath 1, it makes a strong effort, triggers. On 2, makes a slightly less strong effort, still triggers. And 3, even less strong effort, and nothing happens. So I guess that's a good analysis.
Yeah, so I guess that the threshold here, it was not met. And so
right.
and that's why I'm wondering if this pause that we see over here, rather than refractory, just like this one, it's just the ventilator closes the valve to try to let the pressure drop to that level. I don't know how, I mean, this is a servo eye, it seems. And so I wonder.
I don't know.
Yeah. So let me pause there for a second. I'm looking at a couple of comments. Let me see. It says breath 1 and 3. If it's pressure trigger, the P goes down to baseline from PIP of yes. We suggest that it's working, hard to trigger. See the expiratory flow on trigger breath number 2. Yes, and before and not the patient. Can you explain what you're trying to say? I mean, it's a little bit cryptic what you wrote on the chat.
Well, I'm trying to say that since we have the compliance of the circuit and the patient in line, most of the time the first emptying comes from the circuit, and they look pretty similar. So I think that it's not fully the patient; it's mostly the circuit, the kind of spike we see.
Well, it seems that it exhaled if you go from here all the way to down here. That looks a little bit more than the tidal volume of the circuit, I would say. I mean, it looks like 100, I don't know, 200 cc's.
Yeah, circuits compliance around 2 or 3 milliliters per centimeter of water. So that seems like
in this case, my calculated compliance of the patient seems to be very low. So that means that maybe the patient has more room to expand or more pressure to expand. But I might be wrong.
Yeah. I think that this is all a pressure trigger that was set to try to control some of the discordance that they were seeing, and trying to lock the patient out, not recognizing what was going on, and they used a pressure trigger. So the question for the audience in general terms is, now that you have seen that there's all these problems with triggering, which seems to be that the patient is going at its own at its rhythm, and sometimes it triggers, sometimes it doesn't. How would you solve this? What strategies do you have? You can see patient is on a PEEP of 5, FiO2 of 45%, a rate of 26. On PRVC, any options here that you would think if you were in front of this patient? And let's assume, because I know that this is going to be the first question, Eduardo, what's the goal? And so let's assume that the goal for this patient is comfort. Thank you, Lorenzo Oliveira. The right question, Lorenzo. Very good. Exactly. So that's what drives your decision, right? If your decision is safety, then you may be moving towards a different question, which is sedation and whatnot. And so Lorenzo is saying, well, let's move him to CSB. So there you go, Philippone. If safety is likely sedation, it's one of the possibilities, because this patient is working hard to breathe. But if it's otherwise, you probably want to free Willie and let them breathe on their own and figure out where they are and why are they breathing so hard. So there's an interesting one here. So Davis talks to us about IMB, and IMB maybe now we have 5 types of IMB out there, right? And so or described IMBs. I know, Rob, is that letter out?
It'll be out in about 2 weeks.
Excellent. So I think that from all those IMBs that exist, perhaps one of the IMBs that you can think here in a patient that you're concerned about comfort, but also safety, would be to actually activate the auto mode on this patient and then see how the patient does in terms of tidal volume and whatnot. It may not be enough. It may be that you need and that's a type 2. And the reason why we do a type 2 would be because it shuts off the mandatory breaths when the patient is breathing on its own. And so that's a possibly positive thing for this patient. I saw they're liberate the TI and change the targeting scheme to set point. Yeah, and you can also, those are good points. So it's CSB, so pressure control CSB, that would be pressure support, for example, or PAB, or even consider NAVA if the scenario warrants this action. Very good. Other comments or questions? Is there an early to fix? Oh, I love it. Thank you, Mark. So let's discuss a little bit the flow waveform, and this flow waveform requires you to pay attention to a couple of things. So the first one, and we reviewed this at our last SEVA VentRounds, episode 76. This is 77. When you the volume waveform starts at 0 because the ventilator resets when the breath starts. So it starts at 0, it goes all the way to the top, and then when you restart the next breath, so you see here the patient exhale this amount, and then the next breath starts, the ventilator resets to 0, and so it's resetting because this breath was stacked upon the other one. So it's not a leak per se. It's not that the patient only exhaled this amount and the rest went out into the environment. It's that the patient exhaled this amount, and then the patient was doing effort in and trying to inhale to a closed valve, and then boom, it opened, and the patient got this amount of breath. And then when the next breath comes out and the patient exhales, you actually can see the breath goes below the baseline. So the patient seems to disappear, and if we had more gain here or more screen, this probably would go all the way down, and then it would reset up to the next one. So now could there be a leak? Absolutely, but I would say look at this next breath, and this actually kind of confirms the statement. You see that it reset to 0. The patient breathes in about the same amount as over here, right? Then tries to inhale, it's not getting any breath because the valve is closed. And then finally the patient releases. And when it releases, it comes all the way down. So could the patient leak? Yeah, there could have been some leak because it's pretty discordant But I would say that this is, in this patient, probably the cause is that there is a lot of discordance up here that it's leading to a reset of the ventilator earlier on.
And I would think that if there was a leak, then that pressure wouldn't drop when the patient was breathing in. He'd get a little
Yeah.
bit of flow. Still couldn't trigger, but you'd see if there was a leak, he'd suck gas through the leak, right?
Yeah, and the pressure may not drop actually as
Yeah,
much.
that's right, right, right.
So that's a great comment, Martin. Really good. Excellent. So, I mean, I hope this has helped you recognize the different types of trigger discordances. Read a little bit better the waveforms, see how a closed valve looks and the pressure drops. Things that we are that came up that it's important for us to define, especially when you're creating a taxonomy, is what is an early trigger. I mean, is it there has to be a period of time that you use to define it, because it could be a missed or failed trigger, or it could be a early trigger, depending where it falls. And those are important things to highlight. Here is the code for the CME for our CCF caregivers. If you are an RT, you can get your CRCEs. They are free and high quality. And as usual, send us your image to me, to Twitter, or to Rob or myself via email. Here's a bunch of resources related to SEVA, and all the prior episodes, the 75, are out there. Then the next 2 will be posted at the end of the week. And with that, I'll stop and thank you, and see if anybody has any other questions or comments. Excellent. Well, thank you very much. Have a great day.